Very slow. Yeah, we can start.
1 more minute, yeah?
Yeah, no, it's right. It's already it's stream. You are live, sir.
We are live, but 3 minutes are still there too.
Okay.
Oh, 257 only.
We'll start at 3, Swaksha.
Yeah. Right.
Previous shot.
So who will, sir, Jara sir, you will go first or I will start?
You go first, absolutely. No
Yeah.
problem.
Okay.
Dr. Saab, I wanted to interact with him. I wanted to say hello to him.
Sure.
I know him for how many years, sir? From 15 years now?
Almost around 10 years, sir. For past 10 to 12 years.
10 to 12 years. We met during a conference, I think.
Probably in the conference. Initially, yeah, mainly in the conference.
Mainly in the conferences. We used
In
to
the
meet.
conference.
Yeah. Then
Yes.
we established
You will
contact.
not be seeing very frequently now.
Now Dr. Saab has become our regular speaker. He has given some
Last time we had a session one Sunday. Good session it was.
different diseases.
Sir, if you can stop sharing, I will start and introduce you, then give it over to you, sir. Is that okay?
Stop my sharing. Okay.
Yeah. Where is it?
Yeah, ma'am, we can start at.
Yeah. Okay.
Yeah, we can start.
All right. Good afternoon, everyone. On behalf of Micro Knowledge Academy, Micro GTF Division, it gives me immense pleasure to welcome you all to this webinar. I am Dr. Manjula from Microlabs, and also I bring greetings on World Digestive Health Day. On the occasion of World Digestive Health Day, we have this very special webinar, GERD, an old problem with new approaches. And we have a very distinguished gastroenterologist, Dr. Arun, with us, taking us through the newer approaches. As we know, gastrointestinal reflux (GERD) is a common and chronic gastrointestinal disorder with a significant negative impact on health-related quality of life. And you referred the data, in Asia, there has been increase in the prevalence of GERD in the last 10 years. And there are several studies in India available. So these studies have shown that the prevalence ranges between 7.6 to 28.5%. So there are several single center studies. All put together, the range is up to 28.5%. So to discuss this and give us the latest approaches, we are pleasure and privileged to have a very distinguished gastroenterologist with us. Sir is very well known across India, so he needs no introduction. As a formality, I will be introducing him. It's my pleasure and privilege to introduce Dr. Arunan. Sir is Assistant Professor of Gastroenterology at the Department of Digestive Health and Diseases, Chennai. He is currently Consultant Apollo Main Hospital at Chennai. He's also Director of Chandra Gastro, Liver and Endoscopic Center at Chennai. His main special areas of interest include post-liver transplant immunosuppressive guidelines and plasmapheresis in ACLF. He has membership to several professional organizations. To name a few, he's a life member at ISG, INASL, SGEI, as well as IAP. So he has a very distinguished qualification. He has done his pediatrics as well as DM gastroenterology. Very, very unique and very nice to have you. Sir, Dr. Arun, it's very pleasure to have you with us. Once again, welcome to you, sir. And may I now request you to kindly take over and make your deliberation, sir. Over to you, sir.
Thank you, Team Microlabs. Thank you, Dr. Manjula, who gave a very reasonable brief introduction about me. And I would like to share my screen right now with you all. Just a minute. My screen is well visible?
Yes, it's visible.
Okay, good afternoon, respected professors, senior consultants, and dear friends. On this World Digestive Day, and also right now we are having a terrible pandemic season which has been going on for the past 1 year. And in this World Digestive Day, the most important scenario, we are going to look into that. And thank you, Microlabs, who are being here to give an opportunity to discuss about that. Nothing but the most common entity, what we are called as gastroesophageal reflux disease. So right from a child, we will be coming across this condition, and we'll be looking into that from your day one of medical knowledge until now. We will be looking into this common clinical scenario, and without this, even the physicians, surgeons, and any consultant gastroenterologist will not be leaving, even cardiologists will not be leaving the OP without seeing this kind of presentation. And how many, with this presentation, we will be having a varied clinical representations, and how we are going to manage this kind of presentation, the most important area for me to tackle, and what are the various recent advances in this area to be considered right now in 2021 for updated management guidance as to be there. And so our topic is going to take on with an old problem of GERD with new approaches. So what is this GERD? As well know, so it's nothing but a gastroesophageal reflux in which your contents of gastric content is going to reflux it into your esophagus. So once it's going to reflux it into your esophagus, what's going to happen? It's going to cause a major troublesome symptoms in which you are going to have a worsening of events. There are multiple definitions for that based upon the Montreal's one of the most important definitions being considered that. So the cardinal presentation. So what is a cardinal presentation? I'm not going to each and every line of a slide. My intention is to, when you're going to leave this session, you need to know what is the key thing we need to remember, what are the various updated guidelines, if anything is there. What do you mean by refractory GERD? How are you going to manage a patient with refractory GERD? What are the latest endoscopic innovation which has been happening right now in the management GERD? All these things is my area for you to discuss with you very, very briefly. And if you're going to look into that, the cardinal presentation of this GERD is nothing but heartburn and regurgitation. Most of the patients, around 80 to 90% of the population in India with GERD will be having this kind of presentation. So it can also be presented with extra esophageal manifestations that I'll be taking over in my upcoming slides. And sometimes it will be having chronic cough, asthma, and chronic laryngitis. Other various extra GI manifestations can also be reported. If you're going to look into this prevalence data, almost around 7.6% of the data is going to be prevalent in rural areas as well as an urban area. It will be going around 16.2, and the estimated overall prevalence will be around 10 to 20% year over year, and less than 5% will be in Asia, will be reported. So what we are going to look into this data of GERD, the most important thing, and if once see many patients who have been seeking, most of the time they will not be having major symptoms. They will they will be having minimal heartburn, other symptoms for which they will not seek medical attention. By the time when the patient is going to reach a gastroenterologist after seeking the primary care physician's attendance, by the time when they're going to reach gastro, so it will be almost in the tip of iceberg. But very few symptoms. Only those persons who are going to have persistent symptom or refractory GERD will be landing with gastroenterologists, for which they will be landing with some complications that I'll be discussing with you all. So why do we need to know about this reflux? So as we all know that there are 44% monthly data are being there, and 4 to 7% daily data are being there. And this is how the most GI patient visit will be there to a gastroenterologist for GERD. It's the most common scenario for the physician. Now we are going to know about physiological mechanism factors, pathogenetic mechanisms in which it's going to trigger the process of GERD. As we all know, the lower esophageal sphincter, the flap bowel mechanism, all those things has been the most important, because we are going to do an endoscopic intervention. We are going to tackle only the lower esophageal sphincter as well as the flap bowel mechanism. Everything has to be maintained well. So what is this clearance mechanism of esophagus? What is this mucosal integrity? And what is this lower esophageal sphincter complex? We all know that the lower esophageal sphincter pressure has to be maintained in the range of from 20 millimeters of mercury. So if it is going to fall, and then the TLECR is not going to be activated properly, so that will predispose to your gastroesophageal reflux. And based upon your gastric emptying, how rapid your gastric emptying has to be there, all those things will be the major physiological mechanisms of being involved in the diagnosis of GERD. So what is this pathophysiology? The main contributing factor, if I'm going to look into that, the major impact esophageal clearance. If your food is going to stay over there for a longer period because of gastroparesis and other things, impact salivary function because of bicarbonate. Bicarbonate has to be there to neutralize your secretion. If the bicarbonate secretion is not going to be well adequate, and impact mucosal defense based upon your and your resting pressure of your lower esophageal sphincter if it is going to come down, and when you're going to have a delayed gastroemptying, for example, in various clinical scenarios like diabetic gastroparesis, and when you're going to have even a duodenal-gastric reflux or pyloric incompetence or transient inappropriate relaxation of ileus and various acid secretion, gastric acid by pepsin secretion, all those things are going to contribute to your pathophysiology for this ileus. And what is this ileus competence? If you're going to look into that, the four main components of being looking into this ileus is mainly by crust of diaphragm and intra-abdominal portion of esophagus, your angle of face and phrenoesophagus. This is how your ileus, distal 3 to 4 centimeters of your ileus is going to be maintained by the strong competence mechanism. So what is going to happen in this TLECR? It will be lasting for more than 10 seconds. So what is going to happen? There will be high possibility for your stomach to get distended with gas and other liquids. Once it's going to get distended, there is high possibility for you to go for the reflux phenomena. This is how the belching mechanism is going to set in, and followed by once your stretch receptor is going to stimulate and your vagal mediating factors is going to get activated, followed by your TLECR is going to get augmented, followed by you may have a gastroesophageal reflux presentation. What is this swallow-induced relaxation? Once you're going to have, this is another mechanism for your GERD. Almost around 5 to 10% of the patients in this category will be falling in because of incomplete peristalsis, what's going to happen, and no proper crural relaxation, which is the predominant picture in case of iatrogenia-induced GERD. And next to that, your ileus, lower esophageal sphincter, if it is going to be hypertensive, and next to that, if you're going to be landing up with iatrogenia, like as we all know, as per its classification, stage 1, 2, 3, and 4, the iatrogenia can be categorized in any areas. Once, if you're going for 3 and 4, you'll be having worsening of reflux-like presentation as the day goes on. So what's the common manifestations for every person who are being landing up with GERD? If you're going to look into that, the common presentation is always heartburn. You may have soreness in your throat, chest pain, retrosternal pain, and so a bitter sensation in your mouth. There are so many presentations. Very frequently we'll be knowing into that. And this is how the Montreal has been established, the classification of GERD. If you're going to look for esophageal symptoms, if you're going to look for extra esophageal symptoms, what is an esophageal symptom? That means symptomatic syndrome if it is going to be associated with any reflux syndrome or any reflux chest pain syndrome. Other than that, if the patient is going to present with any significant esophageal injury like esophagitis, stricture, Barrett's esophagus, esophageal adenocarcinoma, these are also can predispose to esophageal syndromes associated with a significant esophageal injury. But what are the various proposed mechanisms for extra esophageal manifestations? Like it could be established or proposed like cough, has been discussed, cough, laryngitis, pharyngitis, sinusitis, all these things, because both the esophageal and your tracheal pathway will always going to innovate in the same microinnovation tract, which is going to happen. That's why extra esophageal syndromes is also going to be reported if you're going to land up with this GERD. How are you going to approach a patient with GERD? How are you going to diagnose a patient with GERD? Is there any significant tests being available to diagnose GERD? What are the latest innovation is being happening in this diagnostic of to aid in diagnosis of GERD? Once the patient is going to land up with refractory GERD, how are you going to tackle all those things? It's the most important area to take on right now. So is there any role for barium swallow? Not much of significant role, apart from if you're going to consider any of the malignant pathology. Apart from the endoscopy, there might be some role, but not in the initial presentation. If you're going to suspect a erosive esophagitis, there might be some beneficial role for endoscopy, but not all for the first presentation. How are you going to monitor the ambulatory pH monitoring, esophageal motility, and what way it's going to help you? So what is this endoscopy? Always you should do endoscopy only if you're going to survey alarming symptoms for a patient who presents to you with suspected GERD-like presentation. For example, if the patient is going to land up with dysphagia or significant weight loss, in case if you're going to have any bleeding manifestations, any bleeding signs, upper GI bleeding sores, if the patient is going to have any anemia and findings of a mass, a stricture or ulcer, these are all persistent vomiting. These are all always you need to have alarming focus in these areas for which the patient has to subject for endoscopy. So a worsening alarming picture need to subject it for a patient for endoscopy is the most important thing. And endoscopy, through upper GI endoscopy, you can able to evaluate the GERD completely. Apart from that, you can categorize in which grade of esophagitis it's been A, B, or C, or D as per lozenges, and you can assess whether the patient is going for Barrett's, is there or not, when which the squamous is going to be metaplased to columnar epithelium. Apart from that, whether the patient is going for peptic stricture, whether it's going to present or not. So in which, based upon your endoscopy, you can classify. Don't think that always if you're going to have GERD, you need to have a presentation of erosions in the GI tract. There are many patients, almost around 50 to 60% of the population will be having a non-erosive disease. You'll not be getting any finding much in endoscopy. Most of the time will be normal, but even then you'll be landing with this kind of reflux presentation. That's called non-erosive reflux disease. And also if you're going to look around erosions, if it will be around 30 to 40% of it will be predisposing for erosive esophagitis. This is how we are going to classify your erosive esophagitis. Very simple classification, frequently used by your gastroenterologist. So lozenges, what you're going to do in this, if you're going to look into the multiple mucosal breaks, but once the mucosal breaks is being completely extending, almost if it is going to cross more than 75% of your circumference is nothing but lozenges grade D. Grade A, B, C is nothing apart from that if it is going to be minimally involved in that. So to overall the patient, we are going to subject esophageal biopsy. Always, most of the time, biopsy is not indicated unless and otherwise if you are going to suspect any eosinophilic esophageal, in which we are going to look for the eosinophil count, if it is going to be more than 15, and if we are going to subject the patient for any evidence of any malignant changeovers, all those things, if you're going for esophageal biopsy, most of the time will not be indicated if you are going to manage a patient with simple GERD. And next to that, what is the role of esophageal manometry? So always you should look for esophageal manometry if you're going to see any evidence of motility disorder. So in this role, there is not much of beneficial effects if you're going to assess a GERD, but it can also assess your LES pressure, your location and relaxation, and it will be it will also aid in assessing the peristalsis and prior to any, if at all, if you're going to subject the patient, once the patient is going to landing up with refractory GERD, then prior to any anti-reflux procedures, then you can subject the patient for esophageal manometry. And if you're going to have a worsening of presentation, then you can consider the patient for esophageal manometry. And the most important indication you need to do is a pH monitoring. How are you going to do if the patient is going to, even after PPI dose for a period of around 8 weeks of therapy, if the PPI followed by the patient's symptoms is going to persist, we need to go for a pH monitoring methodology. Can be considered right from neonatal period, and from elderly population, we can go for 24 hours ambulatory pH monitoring. In that, we can able to quantify the reflux predominantly in proximal as well as your distal esophagus, and your frequency and duration of reflux episodes, and your DMIS scoring, and you need to see all those things by your pH monitoring. What is this 24? It's one of the gold standard in diagnosing for a GERD. So what are the major indications for this 24-hour pH? Who does not respond to PPI? And next to that, if you're planning any surgical interventions, and if you're going to land up with any atypical presentations. So these are all the major indications for pH monitoring, and you can use either a wire pH or you can go for a wireless pH monitoring. That means you can go for wireless pH monitoring, nothing but Bravo capsule, and so many other things are there. And if you're going for it is based upon your transnasal catheter guidance, you can go with the 24 hours pH monitoring also. And what is this DMIS scoring system? If you want to look for this 24 hours esophageal pH monitoring, if your reflux, if it is going to be more than 14, that it indicates there is high possibility for you to land up with gastroesophageal reflux, which means you how many times various postures in supine or in upright, how do you going down, whether your reflex episodes, how many times is going to happen over a period of more than 5 minutes, how many reflex episodes is going to land up, all these things has to be taken into account to calculate this G-means scoring system. So how are you going to approach this patient if you are going to have a suspected GERD, and once you are done, you have proven the GERD, followed by what you're going to do, you need to see whether the patient is having severe esophagitis. That's what I've been told with lozenges C or D, and we can do with a positive pH testing. If you're going to have a positive pH testing also, then you can subject the patient for 24 hours impedance monitoring. But in case of unproven GERD, if you're going to have any alarming symptoms like Barrett's, peptic, or if you're without any evidence of severe esophagitis, or if you're going to have any atypical presentations, then you can go for catheter-based wireless pH monitoring or a 24 hours impedance monitoring on off PPI. So you need to switch out. You are supposed to stop your PPI therapy for a period of 1 week, and followed by you can subject the patient for once the patient is going to land up with this kind of presentation, we can go for pH monitoring methodology. So with this, we need to say that what is your acid exposure time? Because of that, so once the acid exposure time, if it is going to be more than 6, it shows a high possibility for you to land up with GERD. And if your reflux episodes, if it is going to be more than 80, it indicates you are always having an abnormal presentation that shows evidence of significant pointer for you to consider it's GERD. And this is how the most important latest classification being, see, always you should not think only about it could be because of reflex hypersensitivity, or it could be because of non-erosive GERD. So many other focuses there to look into that. So how are you going to arrive at the diagnosis? See, based upon your 24 hours pH monitoring is the most important thing, whether you are going to subject the patient with 24 hours pH monitoring with PPI or without PPI. Suppose if you're going to use that with PPI, you need to look for reflux burden is there or not. If it is still there, then there is evidence of persistent or refractory GERD. But reflex burden has come down, but symptom association is still there, which means it's a terminology, what is called as reflex hypersensitivity. Most of the time, reflex hypersensitivity, you need to go for other line of medications rather than considering the patient for PPI alone. Next to that, if the patient is going to present with normal reflux burden and negative symptom association, which means the symptoms is not predominantly due to reflux, we need to always consider the alternative diagnosis. The same methodology what we are going to replicate here in study without medications. So if you're going to look for all these symptoms, you need to categorize whether the patient is having reflex hypersensitivity or whether the patient is going to have persistent GERD, or you need to consider the patient as alternative diagnosis or any evidence of functional heartburn, any other alternate diagnosis to be considered. All these things based upon your pH monitoring as well as your clinical presentation. So this is another modality which will be aiding you in diagnosing this multi-channel intraluminal impedance that can also be considered if you're going to look into that. So this is also being aided in diagnosing GER, which is sensitivity almost around 77, with the specificity almost around 85 to 100%, in which we are going to place 2 electrodes when a liquid, semi-solid or gas bolus, which is going to move in between them. So what is the beneficial role if you're going to combine your esophageal pH monitoring with your impedance? So what is going to have if it is a pH and all those things, impedance manometry with your pH monitoring, if you're going to combine this, multi-channel impedance and pH monitoring. So what is going to happen? It can able to identify your reflux and non-reflux episodes, and it can able to distinguish your swallows, either antegrade or retrograde flow, and it can able to identify the refluxed contents properly, whether it is because of liquid or gas, all these things, the non-acidic, this is how the mechanism combined pH and impedance monitoring is one of the most significant points that can be taken into account if you're going to manage a patient with GERD. And this is how the wireless capsule, Bravo capsule, there are so many other systems, have been Sandel system, so many other things are there. So if what we are going to place this wireless capsule Bravo just around 5 centimeters above the G junction, in which we are going to, it's a rather than placing a catheter-based, it's a wireless capsule, we can use that. But if you're going to use this, the tolerability will be better and clinical utility is definitely will be high. But there are some certain difficulties in assuming recording the non-acidic reflux episodes if you're going to use Bravo pH capsules along with that. This is what is the latest guidelines has been taken from 2021 paper. What has been mentioned? If you're going to record for endoscopy, and how do you categorize the patient based upon your reflux symptoms? So there is shows some evidence of pathologic reflux or borderline pathology or any supportive evidence, or what are the various evidence which goes against reflux. So what is by endoscopy, if you're going to see stage C or D, a severe esophagitis, a Barrett's mucosa of long segment, as we all know that, and if you are going to have severe peptic stricture, and if your acid exposure time, if it is going to be more than 6, that shows a clear pointer for evidence of conclusive reflux is there. And apart from that, borderline pathology, your acid exposure will be in moderate range, will be around 4 to 6, and your reflux will be around 40 to 80. And adjunctive things will be, if you're going to these two newer pointers, which mean mean nocturnal index and along with post-salivary swallow, all those things can be considered as a new phenomena in the management of GERD. And if your acid exposure, if it is good, episodes, if it is going to be less than 40, which means there is significant pointers to go. And we can go for high resolution manometry technique if you're going to suspect hiatus, or if you're going to suspect any hypomotility disorders, or if you're going to subject any hypotensive esophageal gastric junction. So this is how we can diagnose through endoscopy if you're going to use biopsy, or if you're going for 24 hours impedance or combined pH monitoring method, along with you can able to analyze your post-salivary swallow as well as your mean nocturnal indices. All those things can be calculated properly in the management of a GERD. So now the most important thing for me to take on is GERD management. As we all know, the most common thing, the diet and lifestyle modification is the most important thing. Your diet and everything has to be tackled. And sometimes we can subject the patient with PPI. Once it becomes refractory, the patient will be promptly referred to a gastroenterologist. So what we are going to do, we need to assess whether the patient deserves endoscopy, or as we discussed with you, whether the patient is going for manometry, or if 24-hour esophageal pH monitoring, all those things we need to see. And what is the medications, what are the line of modality of treatment we are going to initiate, either we're going to subject the patient with H2 receptor antagonist for non-erosive reflux disease, or sometimes we need to go for procaine. If you are going to look into that, for non-erosive reflux disease, if you're going to manage with PPI, the response will always be low, almost around 30 to 40%. But when it comes for erosive esophagitis, the response will be around 50 to 60%. Rather better if you're going to use for erosive esophagitis, rather than combine these medications for non-erosive reflux condition. So in which we need to consider other line of modalities of treatment has to be ascertained properly. So when you're going to subject the patient for surgical line, when you're going to subject the patient for any endoscopic interventions, any new add-on to that, these things I'll be checking on right now with you all. So what is this GERD symptoms? If it is going to present showing evidence of esophagitis, if it is not going to be known, then we can subject the patient with single dose. If it is not going to respond, we can improve the dose, slightly augment the dose, and still no better, we can categorize the patient as refractory GERD. So this is the basic approach from 2019 paper, what they've been taking into account. So once you're being subject the patient with PPI, we need to see whether this patient is going to have improvement or not. And if the patient is not going to respond, we need to see whether the patient is going to have any typical symptoms or any atypical presentations like any other extra esophageal manifestation. So if the patient is having typical symptoms, then we can subject the patient for endoscopy, followed by you need to assess abnormality, the esophageal esophagitis or severe erosive esophagitis. Based upon that, you can consider the patient for specific treatment, and atypical symptoms promptly refer the patient to the specific consultant. And next to that, if the upper endoscopy, if everything is going to be normal, then that's a ideal point for you to consider the patient for reflux monitoring. If you're going to have a low pretest probability, high pretest probability, then we need put the patient on medication with impedance pH monitoring. But low pretest, you can also switch off the medication, and then you can consider for impedance pH monitoring. So lifestyle modification around 20% can be reasonably effective. When you're going to add H2 receptor antagonist, then around 50%. Single dose PPI 80, and increasing dose of PPI can up to 90 to 100% efficacious rate is still being reported. As well, the basic line of management, if you're going to look into this diagram, see, always you need to elevate your head end of the bed, turn towards your left side, and never, Avoid eating your food within 2 to 3 hours, and don't go for high fat dense food. Always avoid the eliminating alcohol and anything which is going to augment your LES. You need to reduce it out because that will predispose you for your low esophageal sphincter mechanisms. Apart from that, you need to avoid your fat and fried food and peppermint chocolate. All these things has to be done. And OTC medications, many consultants are being using that. But once a patient is going to, in what way this diet and lifestyle modification is going to help you? If you're going to lose your weight, it's going to happen. The lower esophageal sphincter is definitely, the gastric contents is going to come down. Reflexity of gastric contents is definitely going to come down. How the mechanism is cytokines, interleukin pathways, and tumor necrosis factor. These are all the major things. If you're going to more of visceral fat, which will affect your lower esophageal sphincter. So what is supposed to do? You need to go for a weight loss. Definitely is going to have a significant impact. If you're going to have a significant high weight, there is high possibility for you to land up with a worsening of your GRD presentations. And what is the thing? Even if you're going to reduce your weight, even if you're going to cut short your activities, these kind of symptoms, this kind of management will be effective only if you're going to have a mild to moderate presentation. But once you're going to land up with any severe esophagitis or worsening of symptoms, if you're going to land up with refractory GERD, the possibility with diet and lifestyle modifications, there are many papers to quote that the beneficial role of all those things is still a questionable issue only with diet and lifestyle modification rather than subjecting yourself to medication. So this has to be considered along with that, but it not be considered alone. That's the most important thing for you to think in terms of. And the basic medications, antacids, as we all well know, the first line of drug, most of the practitioners will be using this. Nothing much to discuss in this area. And you can think only one thing, alginic acid preparation can be considered. If you're going to look, what is going to form? It is going to form a raft which colocalizes the postprandial acid pocket. And once it's going to displace below the diaphragm, resulting in significant suppression of your postprandial acid reflux. So alginate preparation can be tried. If you're going to use around 40 ml per day, there are papers to quote that. For a 14-day trial with omeprazole, there is some effective evidence has been shown even in BMC Gastroenterology Journal from 2012. There are some papers to show that. But what are the various merits? It's very easy to administer. Prompt acid neutralization will be there. But what are the various demerits for that? If you're going to look into that, your esophagitis is not going to heal completely. And frequently, you need to repeat the dosing. And various toxicity, aluminum toxicity, magnesium toxicity, as we all know, it can cause diarrhea, and aluminum toxicity, it can predispose to constipation and osteomyelitic-like presentation. There are so many other things for alginate. Nothing much to discuss about this antacid preparation. And the other area for us to take on right now is H2 receptor blockers, in which the main role for H2 receptor blockers we can use for nocturnal acid breakthrough. It will be definitely able to come down. Suppose if you're going to put the patient with PPI, if you want to stop the nocturnal acid breakthrough reflexes, we can definitely combine H2 receptor antagonists. Will be having a significant effect. And there are a huge list of H2 receptor antagonists. The recent add-on to the market is mafetidine. And if you're going to use this H2 receptor antagonist, no much of side effects, cost effective, definitely you can use very well. And grade 1 and 2 esophagitis, there is significant response. But once a patient is going to land up with stage 3 and 4, the healing rate will be around 30 to 40%. The response rate will definitely is going to come down if you're going to use H2 blockers alone. So these are all the demerits. And one main demerit, what you're supposed to remember, that tachyphylaxis, which means once you're going to administer the dose continuously, your response is going to come down. So your grade 3 and 4 reflux will not be having much effectiveness, and tachyphylaxis is definitely a significant a problem to be analyzed if you're going to manage a patient with H2 blockers. And side effects are very limited. Rarely gynecomastia, as we are well known about cimetidine, and drug interactions, not much with that. And apart from that, the most important entity is PPIs is one of the main, because dual release PPI, single dose PPI, double dose PPI, various regimens are being tried, various PPIs, and now other drugs are also being there in the market for it to be in use. So what is this hydrogen potassium ATPase blocker? So if you're going to use this PPI for a long, so what is the role of PPI? If you're going to look into this, this is how the parotid cell, what is going to happen? The hydrogen ion is going to secrete into your stomach, and followed by more of hydrogen ion secretion, which will be predisposing to more of acid accumulation into your stomach by influxing your potassium. So it will be having, once a hydrogen ions is going to get accumulate in your stomach, gastric lumen, acidity will be worsening, and the pH is of more than 4, it's going to happen, and less than 4, it's going to worsen. This is how your parietal cell mechanism is going to set in by your gastrin, ACH, histamine, all this pathway is going to be augmented, and followed by your PPIs, inhibitors is having a significant role. So what you're going to do, once you're going to use a wide list of PPI, like esomeprazole, we all well know that frequently we'll be using one good molecule if you're going to look into that, and lansoprazole. So many other molecules can be considered, but the main thing, we need to give this patient a potential role. We need to either give a morning single dose regimen, or we can go for double dose regimen, or we can go for dual dose regimen, but it will take some time for this acid pockets to get inhibited, because it will take minimum 4 to 6 hours for those PPIs to block the parietal cell activation. So that is how it will be taking a delayed effect, delayed onset of action. And once it gets set in, it will be taking some more time. It will be acting only for 24 hours, sometimes followed by, again, your acid pocket is going to get accumulated in the parietal cell. That's how your effect is going to get diminished with this. So we need to subject the patient with repeated dosing, sometimes if it is going to be needed for a period of around 8 to 12 weeks based upon your clinical presentation. So double dose PPI, nowadays, many things, single dose regimen, high dose regimen is there. And this is how step up and step down H2 blockers with antacids, PPI only on demand, not much of use. Lower dose of PPI, stepping up of PPI to double dose regimen can be considered in the management. Always the merits is having a significant impact, the cost not much high, reasonably effective apart from that, and it will be maintaining your pH at a rate of around 4. It should be a grade of greater than 4 has to be made in for a period of at least 10 to 14 hours. But there are some papers, I'll be showing it to you. So major effects, so well known, I mean, reasonably well tolerated, and it always inhibits both meal as well as nocturnal acid secretion and available over the counter. And some demerits, some adverse effects, as we all know, renal injury. Apart from that, a funding gland hyperplasia, and cost effective, I mean, some molecules are slightly costlier, and it will not be curing reflux completely. And apart from that, your any weak acidic reflux or alkaline reflux or diurnal GI, if these other refluxes, if it is going to be there will be having a minimal response for these kind of medications we are going to subject. So not all the patients who are going to present with reflux disorders will be responding to your PPI. Always you should remember that there are other molecules to be considered in the management. Also, if you're going to land up with non-erosive reflux disease, the role of PPI is slightly less, and these things has to be strongly considered when you're going to manage a patient with PPI. And dual release technology, like so for example, dexlansoprazole, even your pantoprazole, if you're to consider dual release technology is still followed. For the first initial phase of action will be at a rate of around 4 to 5 hours, followed by the second phase of action around 8 to 10 hours of duration. All these things can be added on to the molecule, but esomeprazole definitely having a reasonable potential effect, because if you're going to use esomeprazole, the beneficial role in erosive esophagitis will be always around 50 to 60. It's slightly higher, has been quoted when compared with other multiple papers like omeprazole and lansoprazole. So the beneficial role of esomeprazole in the management is slightly augmenting when compared to omez and lansoprazole in the line of management with GERD. And some bacterial infections may proliferate. Always we need to be very cautious when you're going to subject the patient with PPI. And kidney disease, you need to be cautious. Sometimes acute kidney injury, that's already been discussed. And all these things, osteoporotic presentation, hypomagnesemia, and dietary iron intolerance, all these things can be reported if you're going to use PPI, but these things will take time for you to develop, not for all the patients. Very few of adverse effects can be reported, but safely can be considered for most of the patients. When you're going to use this PPI, the response, if you're going to look into this paper, almost around 70% will be having significant heartburn. Everything is being, most of the time will be having a significant response. Your regurgitation symptom, the cardinal presentation will be having a significant impact if you're going to use PPI. And this is how the recent trial has been taken from the Digestive Sciences paper. And this is what is called an OSCAR trial. If you're going to use optimal omeprazole dosing and symptoms control, what has been mentioned in that, in which they subjected around 64 patients. After 8 weeks of therapy, there will be having a significant decrease in frequency, your severity of symptoms on optional regimen, on optimal regimen. So if you're going to use for that, Optimizing your PPI dosing related to meals will be having your significant outcomes if you're going to subject. And once daily, this is on the recent, this is another paper on which we taken. Once daily dosing will not be going to have a significant impact, because see, if you're going to look into this graph, almost the duration of action will be around 12 to 14 hours, in which it will not be acting for over. So we need to go for double dose regimen or dual release technology regimen if you're going for that PPI modality. So this is all the various papers, and esomeprazole and lansoprazole, if you're going to combine that. So if you look for esomeprazole, the definite beneficial role will be slightly higher when compared to lansoprazole and other molecules in eliminating heartburn, acid regurgitation, your epigastric pain. That's one of the most common cause for your postprandial distress and your functional dyspepsia. They'll be having a significant impact if you're going to use this esomeprazole and other molecules to be considered in the market. And next to that, apart from PPI, what is the role of prokinetic? So this is going to accelerate your kinetic system. So these drugs, mainly inhibits your GER, and it will be acting on your lower esophageal sphincter tone. Gastric emptying will be augmented. Your intestinal motility will be improved. Based upon that, this prokinetic. There are multiple modalities, multiple drugs are there. If you're going to look into that, mainly by antagonize your D2, and also it's going to modulate your 5H2 receptors. Not much of drugs are being FDA approved, and there are so many other molecules for usage of prokinetics like domperidone, isopride, levosulfide, cinetopride, so many other things. Isopride can be safely considered as the D2 antagonist and acetylcholinase inhibitor. Based upon your clinical effects, prokinetics can be used, but you need to look for any evidence of cardiac events. When you're going to be a cardiologist, you need to be very cautious, because some drugs, there is high potential for you to go for arrhythmic-like presentation. So always when you're going to look for prokinetics, you need to be very cautious which prokinetics to all the patients you're going to subject. That's the most important thing when you're going to look for evidence of prokinetic support. This is all the list of dosages: domperidone, isopride, levosulfide, cinetopride being there in the market for consideration. And what is the major merit? It's nothing but it's going to improve your LES tone. It's going to control your heartburn significantly. Not much very. What are the various demerits? It's mainly side effects profile as anxiety, restlessness, and neurological symptoms like extrapyramidal symptoms, rarely with domperidone, other things. Some patients have been reported. So always you need to be cautious to who are the patients you are going to subject this prokinetic support. If you're going to manage a subjected is in the management of GERD. So what are the various drugs that reduce your transient lower esophageal sphincter tone mechanism? So if you're going to look into that, the main drugs, see, if you're going non-erosive reflux, or if you're going to have a low-grade esophagitis, baclofen very safely, as it is a GABA agonist, GABA B agonist, been used for years together for at a dose of around 5 to 20 milligrams thrice daily. It definitely is going to come down with your transient lower esophageal sphincter relaxation. It's going to reduce your TLACR, and also it may be having impact in decrease both acid and duodenal reflux, and there is high possibility for your symptoms of GERD will be improved if you're going to treat the patient for a period of around 4 weeks to months. And demerits, some drowsiness and other neurological symptoms rarely being reported, and other GABA agonists like lisocabal, not much of use nowadays. And this is one of the most important area for me to take on. If you're going to subject the patient with PPI, even after 8 weeks of therapy, if your symptoms are still persisting, there's nothing but refractory GERD. Almost 30 to 40% of patients, we are going to subject the patient with this PPI. There is high possibility for you to land up with refractory GERD like presentation. Chinese multiple papers are there to record the presentation of refractory GERD. It could be because of reflux esophagitis or non-erosive, or functional heartburn, or all these things can be reported if you're going to look into that. And what is this PPI refractory GERD? If you're going to look into that, see, this is how, if you're going to categorize a patient, there are other line of molecules also can be considered, like a nocturnal acid breakthrough H2 receptor antagonist. That's what has been discussed. In order to prevent a nocturnal acid reflux, you can use this H2 blockers. A combination therapy definitely will be having a significant impact along with H2 and PPI. And next to that, a potassium competitive esophagus. In this mechanism, see, if you're going to use your PPI, it is going to irreversibly inhibit your proton pump. But in this, it's going to reversibly inhibit your proton pump by blocking your hydrogen potassium ATPase. As we all know, there are multiple molecules, there vonoprazole, soroprazole, all these molecules can be considered, but still these needs more time to be taken over in the recent papers to be considered. So this is another add-on into the market. The potassium channel blockers can be tried. Apart from that, various antidepressants, once the patient is going for functional hypersensitivity, reflex hypersensitivity, a functional heartburn, all those things, there is a significant potential role for your antidepressants to be considered, like TCAs, SSRIs, will be having a significant impact. Even your vanilloid receptors like TRA, all those things now being in the market to try for once the patient is going to be presenting with a worsening of symptoms or non-response in non-erosive reflux, or if the patient is having other functional events for functional dyspeptic-like presentation. This is a outline of molecules what you are going to consider. The lure molecules like pain modulators therapy, which is going to alter your vanilloid receptor, and prokinetics like macrolides, azithromycin, all those things can be added on to that, but not much of beneficial role to be proven. And this is how we need to analyze your patient if you're going to manage a patient with GERD. So what are the various causes of GERD? Any causes which is going to be unrelated. So major cause, whether the patient is going to adhere to the molecule or not, whether the patient is having functional esophageal disorders, like as I discussed with you, esophageal hypersensitivity or esophageal functional heartburn. And apart from that, whether the patient is having delayed gastric emptying or rapid PPA metabolism or eosinophilic esophagitis, all these things to be considered, or any other causes which is being unrelated to GERD, like your Zollinger-Ellison syndrome, in which the fasting gastrin level is going to be very high, your pill-induced esophagitis, if you're going to use tetracycline, iron-like preparations, can you have a worsening of symptoms? Any other GI manifestation, autoimmune disorders, or any infectious esophagitis like Candida, other things, so many other causes to be looked into the response to consider the patient for non-responsive PPI. What are the various? So apart from this medical line of management, there is one more most important thing in which we are going to consider this endoscopic intervention. So what are the various endoscopic modalities? So it's been very new into the market. If you're going to consider this endoscopic intervention, very few centers in India have been trying this kind of modality, and that shows some evidence of improvement if you're going to use this endoscopic intervention. And also the laparoscopic and surgical interventions can also be considered beyond your medical therapy in the management of GERD. This is all your esophageal strictures. Because of peptic stricture, any other complications, we can use a dilating devices for which we can use SG dilators, and so many other dilators are going to be available. And what is the various endoscopic therapy which is going to be available? As we all know, this is the outline. If you can use a sewing technology, a burning methodology, or you can use a knife on surgical procedures. You can put an implant, a magnetic implant, or you can do an endostimulation. These are all the therapies which may available. Briefly, I'm going to look into that. So this is a baseline chart right from various papers from your level of team. You're going to look into that. You want by radio frequency ablation, and one other, and next one is transoral fundoplication, and next one is mucosal resection. So in transoral fundoplication, esophageal, Muse, and Gerd procedure are there, in which I will be showing the outline how you're going to look into that. And mucosal resection, nothing but anti-reflux mucosectomy can be tried. What does this RFA, radio frequency ablation? If you're going to look into that, is one, if you're going, it's the main thing in your G junction. So you need to pass 4 needles and 4 channels, in which you're going to use a radio frequency current to ablate. So mainly once you cross the G junction, you need to use a radio frequency current to ablate. What is the mechanism? It's going to augment your sphincter. So your muscles is going to get thickened out. So once you're going to sphincter gets augmented out, it will be preventing the reflux. So that's the main mechanism for this radio frequency ablation procedure. And what is it? Nothing but strata. It's called a strata procedure that can be done, but there are some problems if you're going to use this procedure. There is evidence of gastroparesis, your erosive esophagitis, esophageal perforation can be reported, but you can do this procedure as an outpatient procedure within a period of around 60 minutes. You can easily do the procedure, you can walk home comfortably, in which main thing, the modality of action, you need to augment your muscles. It's the most important thing. And this is next modality of endoscopy can be considered, but these are all is very tough and very competitive. And when you're going to use it, you should need be a high, tertiary care centers. Most of the tertiary care centers only can be able to do all these procedures. And what is this barred endosclinch? If you're going to look into that, you just go beneath the G junction, suck the mucosa just beneath the Z line, and your needle is going to be preloaded, your suture is going to get advanced. Once it's done, you need to clinch and cut the catheter advanced to tissue, and final placation in your cardiac can be done. This is how your barred endoquinch procedure can be tried. You need to apply the plicator into your cardia. The final appearance will be like that. So there will be some merits, minimally invasive, and demerits, possibility of perforation, other things, and retrosternal pain, short vomiting, bleeding episodes can be there. And next to that, this is what is called as esophageal. So this is nothing but a transoral incisionless fundoplication procedure. So what is this esophageal? What you're going to do, what we are going to do, you need to apply a helical plicators. So in this, we need to drag the tissue, and almost around 20 fasteners what you're going to apply across your G junction, in which it's going to create a partial wrap in your anterior portion of your stomach. So what is going to happen once you're going to create a partial wrap of your G junction? What's going to happen? It's going to form a flap mechanism. It is going to prevent your reflux. This is how the esophageal procedure is going to be there. So helical applicator, this is what has been showing in this diagram. You are going to use in that. So you need to drag the tissue, followed by you can use this. And there are merits that we minimally invasive procedure. In hiatal hernia patients with symptomatic chronic GERD can be considered in the management. Apart from the demerits like vagal nerve deforming injury, all those things can be reported if you're going to use your esophageal. And this is what is called as Gerd procedure. So in this, what you're going to do that it's an endoscopic full thickness plication. So just open the arm. What you're there will be a clamp. So in that clamp, what you're going to do, you need to open the arm, you need to fix the tissue, and mainly you need to do the Gerd procedure from your greater curvature. Greater curvature of the stomach mainly is to be used. And what you're going to do, once you're going to apply, and you need to fix it out, followed by using a fluoroscopy, you need to augment the procedure. Along with that, if you're going to use your fluoroscopy through the transnasal endoscopy, you can access into that. And Gerd procedures, so many recordings, so many things are being there, but very few centers are being tried this modality of procedure to be considered in the treatment protocol. And apart from that, what is this injectable material? So we can inject. There are some trials are being there, but nothing much of significant role has been proven with that. Like Entrex, your plexiglass, and apart from your Duras can be considered as an injectable material from 2005. In 2005, there are some papers to try with that, but some evidence of perforation and aortic puncture, all those things has been reported. So not much of role with this injectable materials nowadays. And what is this Muse system? This is nothing but you are going to use an ultrasonic stapler. In the discipline, there's an ultrasound probe will be there. So this is Medica's ultrasonic surgical endostapler. So if you're going to use that, so what it's going to do, it is going to measure the thickness of your wrap. Once it's going to measure the thickness of your wrap, the wrap distance, you need to calculate approximately on 1.4 to 1.6 centimeters. And once you're going to suck to that, you need to release the stapler. And this is how it's going to create a flap wall mechanism in your lower esophageal junction, followed by you need to take care with your reflux symptoms is going to come down. But this Muse, all the systems still a complicated procedure for you to proceed in India. And you need more expertise to be done. And this is nothing but ARMS procedure. What is that? It's nothing but anti-reflux, other line of modality of endoscopic approach, in which in this procedure, you're going to choose your lesser curvature, or in Gerd procedure, you're predominantly going to choose your greater curvature. So what you're going to do in lesser curvature, you need to target, you need to create artificial ulcer in your lesser curvature. Once an artificial ulcer is going to get healed up, so there will be a healing of your ulcer. The healing of your ulcer will be predisposed you to get formed the scar. The scarring system is going to set in. Once a esophageal scar forms, the esophageal flap wall mechanism get reduced. The esophageal flap wall mechanism get reduced. It will be preventing your reflux. So we need to do your lower esophageal, predominantly this procedure, anti-reflux mucosectomy from your lesser curvature of the stomach. And so with the scar formation, the flexibility is going to come down significantly. So demerits always high with bleeding and perforation rates, and stricture formation will be there. And this is what is called as a Lynx procedure. It's nothing but so in this, what you're going to use a magnetic attraction, a magnetic bead, a titanium coated bead. What you're going to do is you're going to apply in the lower esophageal sphincter in order to reduce your pressure. So what is going to happen is not to augment your pressure, not which your gastric pressure will not be very high in order to prevent a reflux. So this will be acting as a potential thing in order to control a reflux. So Lynx can be done as an OP procedure. It's also a simple thing, but as of now, no much of indicator, no much of considerations in India, which is right now is happening. And the merits does not require any anatomic alterations if you're going to use a Lynx procedure, and cost is slightly a questionable thing. Apart from that, we have been designed to limit the technical variability. Removal procedure was uneven fold. Surgical time is about a very short procedure. So these are all the various things, but demerits are always dysphagia or anaphagia rarely being reported. Always this patient, once the patient is going for Lynx procedure, you cannot go for MRI and other things. So this is what is a basic endoscopic approach. And your surgical modalities for fundoplication, most commonly used, your Nissen's fundoplication, well known, it's a 360-degree rotation. Nissen's fundoplication can be done. Apart from that, there are anterior wrap and posterior wrap approach for fundoplication. Anterior wrap is thigh and door, and posterior wrap is two pads, in which you can consider anterior wrap. You can consider if you're going to have after LR myotomy for the patient with achalasia cardia, you can consider this anterior wrap procedure. The posterior wrap is mainly for poor esophageal motility, as well as these are the main indications in which you need to create a posterior wrap. A two-pay fundoplication can be considered. So various merits if you're going to use this fundoplication. The single time cure, reflux episodes definitely is going to come down. Morbidity and mortality will be low. But demerits always will be there for all the procedures. Bloatedness, flatulence, diarrhea, sometimes dysphagia, all those things can be reported. This is an outline about the endoscopic, like strata, TIF, your Muse procedures. All these things will be having almost equal potential benefits. And some reports are being pneumonia, bleeding, pneumothorax, and all those things has been there. If you're going to, depends upon in what way you're going to get expertise yourself, in what way you're going to use your center is being mastered with what kind of technology. All those things has to be analyzed to whom are the patients to be subjected this line of modality of treatment can be considered. So this is what the summary. You need to analyze the patient, take a proper history for GERD, and look for any alarming symptoms. What are the various indications for the patient to subject for endoscopy? If you're going to subject the patient for endoscopy, what are the various findings you're going to look in? And who are all the patient deserve a impedance manometry? And who are all the patient deserve impedance monitoring? And who are the patient deserves a manometry? All those things to be analyzed. And once a patient subjected to therapy, clinical improvement rate is there or not, all those data you need to calculate properly, and whether the patient responds to H2 blockers or dual dose therapy, and who are all the patient following the strict diet and lifestyle modifications. Analyze all those things completely and tackle the functional events like functional dyspeptic symptoms like functional heartburn, hypersensitive esophagus, your non-acidic reflux symptoms, to whether the patient deserves prokinetic support has to be added, or postprandial distress syndrome has been well tackled. All those things to be analyzed if you want to manage this gastroesophageal reflux. It's not one very simple entity to treat. Sometimes once the patient going for refractory presentation, tackling a gastroesophageal reflux is very complex even at that point of time. Then you need to refer the patient promptly to gastroenterologist for further management. And in these modalities, if it is going to fail, we need to take care of the surgical or else the endoscopic intervention, which is being gastroenterology to aid in the management of gastro. I would like to rest my presentation. Thanking you all for patient listening. I am happy to take up your questions if anything is there to take on.
Thank you very much, Dr. Aaron. It was really very, very nice presentation, and hats off to you. Such a big topic, and you could cover lots of it in this less than a minute hour. Yeah, thank you so much. And then I request all the participants post your questions in the chat box or Q&A. So there's already one question. Can I take this? And this question has come from Dr. Shubhadi Paul. Doctor is asking, what's the duration of PPI in GERD patients?
So always you need to subject minimum duration of 8 weeks of therapy before you are going to label the patient as refractory GERD. But 8 weeks of therapy, whether you're going to use a single dose or dual dose based upon the clinical presentation, weight of the patient, whether the patient is, all those things has to be analyzed if you want to subject the patient with PPIs for GERD-like presentation. So minimal duration should be considered for a period of 8 weeks before labeling as refractory.
Since we started on PPI, can I just ask two more questions related to that? What is the ideal PPI for children? If at all it has to be given, which one is preferable for children?
So ideal PPI, as all well known, sometimes one when given lansoprazole can be given very safely in children. There are some papers are being reported, but always neonatal period, if you're going to use PPI, is not much of beneficial. Once you're going to suspect a patient with neonatal septicemia and other things, always better not to use more of PPI because it will alter your bacterial translocation and other process. So always your pump and damp activation process, also everything will be get altered if you're going to use a patient with PPI neonatal sepsis. So PPI, rather than going further, sometimes H2 blockers also will be considered in the management. And if at all, if you're going in pediatric age group in children, if you're going to subject the patient, arguably lansoprazole definitely going to have a significant role. And next to that, rabiprazole is also being in the market to be considered for a child with this kind of symptoms in the age group of less than 10 years.
Sir, you were talking about a double dose of PPI, right? Sir, in what percentage of your GERD patients, sir, in your setup, that those require double dose of PPI?
So usually around 10 to 20% of the population who are being subjected to PPI therapy, sometimes the patient may need double dose of therapy because our Indian scenario, as we all know right now today, the World Digestive Health Day, the World Digestive Health Day theme is we need to control the obesity. So the obesity and other factors based upon the weight factors, all those things, sometimes the single dose PPI will not be much effective for a patient who are going to subject. Then we need to subject the patient for a double dose regimen or sometimes a dual dose technology, or sometimes high potential PPI like esomeprazole can be considered when you're going to manage a patient with GERD.
Okay. Thank you, sir. Sir, in current scenario, what is the role of H. pylori eradication in GERD?
Actually, I've been forgotten to talk about this because H. pylori we have been going to take on when we are going to discuss something on peptic ulcer disease. But H. pylori eradication, if you're going to consider, if you want, even if you're going to eradicate your H. pylori with a triple drug regimen, or if you're going to go for quadruple therapy, it doesn't going to improve your gastroesophageal reflux symptoms completely. Don't think that if you're going to be treated with H. pylori for a period of 14 days, doesn't mean that your reflux symptoms will going to come down. It can also present, but in no way, no much of potential way it's going to be related. So H. pylori eradication doesn't mean that your GERD symptoms is going to improve. There is a high possibility for you to still have a persistent GERD to be there. So H. pylori eradication is a separate entity that has to be different, dealt in a separate way.
There is one question from Dr. Yoganand. He's asking you, is there any advantage of combining two PPI in a patient at a time, sir?
Combining two PPI is no much of potential beneficial role rather than causing harm to the patient.
Okay, so better to give a double dose of
PPI
same.
prokinetic can be considered. PPI with H2 blockers can be considered. Two PPIs, no much of papers are there to cut the beneficial role because there are, if you all know and look into that, there are some rare adverse effects like around 0.5 to 1% of the population can land up with renal injury and other complications. Always PPI you need to use cautiously. That too for a period of longer duration of time. You need to be very cautious when you're going to subject the patient with PPI therapy.
Sir, there were some issues like prolonged use of omeprazole can cause carcinoid syndrome. What are your views on this?
So mainly if you're going to look into this carcinoid, it's mainly because of a neuroendocrine tumor. It's mainly because of that endocrine cell activation. There are some papers are being there. If you're going to look into this previous data and some case report like follicular cell lymphoma, other trials, I mean, recently I came across some papers in which they've been quoted if you're going to subject that kind of patients with PPI therapy for carcinoid, there is, for PPI therapy, there is high possibility for you to land with carcinoid syndrome. There are few case reports are still being there, but these are all not being the significant pointer to go against PPI. But this all can be added as an adverse events if you're going to consider this PPI therapy for a longer duration of therapy.
Since you spoke spoke about prokinetic agents. Dr. Benjamin is asking, domperidone combination with PPI, how effective it is?
Always, if you're going to suspect a severe reflux esophagitis, a domperidone combination definitely can be considered. But nowadays, there are still very high potential prokinetic is being there. But domperidone combination in a case of severe reflux esophagitis, if it is going to be a persistent, then you can consider domperidone in the management. The symptomatic improvement will be around 60 to 70% rather than using a single dose PPI therapy. But these things has to be done only when you're going to subject over a period of time, not the initial trial regimen itself, not for all patients. You need to subject the patient to domperidone, because always you should remember it may cross your BBB, blood-brain barrier, and it will predispose to extraperitoneal symptoms and other complications. Rare case reports are being there.
Sir, I have a follow-up question to this. Which is the best prokinetic agent according to you for GERD, sir?
So most of the prokinetics are being reasonably well effective, but the best prokinetic what we can consider, as per my personal experience and as per the various papers what they've been quoted into that. So etopride, it's been significantly considered at a dose of around 50 milligrams twice daily you can use. And next to that, nitopride can be considered. Cinetopride, if you're going to use 1 milligram twice or thrice daily, can be considered. But every prokinetic is having good beneficial role. Etopride, even for gastroparesis and other conditions, that is having a significant potential role if you're going to use the patient with PPIs.
So there's one question from Dr. Harshad Sayani. Doctor wants to know what is a diet restriction for GERD.
As we all know, very simple. We need to go avoid a high fatty diet, high sweetened beverages, chocolates, peppermints, all those things. Anything which is going to augment your lower esophageal sphincter relaxation will be predisposing to your gastroesophageal reflux. So reduce your weight, do good physical activity. Aerobic exercise is the most important. Weight reduction is the most important to prevent your cytokine pathway to get activated. And apart from that, 6 to 8 hours of physical activity is the most, in a week, is the most important thing to be considered. But diet modifications, restriction of fat, and avoiding the high sweetened beverages, high carbohydrate diet, all those things with your postural dependence. Immediately if you're going to bed, within a period of around 2 to 3 hours after your food, all those things has to be avoided if you want to tackle this. And you need to elevate your head end of the bed and sleep in a semi-prone position. All those things to be considered if you want to manage a patient with diet and lifestyle modification effectively in the management of GERD.
There's one question from Dr. Yoganand. Is there indication for parenteral levosulfide in GERD?
Parenteral levosulfide we can try in GERD once a patient is going to present with severe gastroparesis like presentation or severe postprandial distress. And sometimes we can even consider parenteral levosulfide. Not much of potential benefits are being proven rather than going for oral oral drug regimen, rather than going for parenteral only if the patient is going to have persistent symptoms, then worsening of events, acute presentation at that point of juncture, even for a persistent constipation, other things at that point of juncture, even if the patient is going to have severe gastroparesis, then we can consider a prokinetics for parenteral origin, not for all the patients to be considered.
Right. Sir, in diabetes, gastroparesis is very common. How do we manage diabetes gastroparesis, sir?
As you all know, the diabetic gastroparesis, because of your innovations, is going to get lost. The vagal innovation is going to come down. All the osteocholinergic pathway is going to be involved in that. So what is going to happen in diabetic gastroparesis? Your lower esophageal sphincter tone is going to be well reduction. It's going to come down. What will happen? Your gastric accumulation, the emptying time is going to come down, followed by, we need to give a molecule in which your emptying time has to be accelerated quickly, for which we need to go for etopride and other drugs. Even cinetopride is going to have a significant potential role in the management of diabetic gastroparesis. But diabetic gastroparesis is one separate entity to be discussed, because there are multiple innovations, multiple tracks are there to be considered, that has to be done separately.
Sir, there are lots of probiotics available. Do you think, do they have any role in GERD, sir?
Nothing much of potential beneficial role has been proven of probiotic. There are some papers to quote the effectiveness of probiotic, even in pediatric age group. There are some papers to quote the effectiveness of probiotic in peptic ulcer disease and other things. But if you're going to alter your bacterial detoxification and other pathways, definitely you can consider probiotics. But Lactobacillus reuteri can be considered. I mean, Bifidobacterium can be considered. But it has to be considered as add-on therapy. But how long you're going to give, how far it is going to be recommended, there are not much of significant papers to prove the beneficial role of probiotic in the role of GERD management.
Okay. So there are no, just one last question, sir. Is there any role of sandhill pH catheter system in GERD, sir?
This is a new entity, Sandhill pH catheter system. What they've been mentioned that it's also been tried like a Bravo capsule. But if you're going to use a Sandhill pH catheter system, if you're going to use Bravo capsule, you need to position it out at a region of around 5 to 6 centimeters distance from the OG junction. But if you're going to use Sandhill's capsule, what they've been mentioned in that, you can go up to around 7 centimeters just above the G junction, in which the potential benefits, the potential effectiveness will always be same when compared to Bravo capsule system. Nothing much of alterations if you're going to be done.
Okay, right, sir. Thank you so much, sir. I didn't find any more questions, and also we have actually exceeded the time also, sir. It was really interesting. Let me see. Yeah, dear doctors, if you have any last minute question, you can post it before we close the session. Right, there are no questions, sir. Thank you so much. Very informative, but there are lots of comments here. Dr. Uday Kumar is telling very informative. Dr. Harshad Sayan is telling thank you very much. So other doctor is telling very excellent lecture. So from our side also, it was really excellent, very, very informative. I'm sure the doctors who have logged in have learned a lot of things, newer updates, and a lot of things in the GERD management. I'm sure it will help them in their routine clinical practice.
Thank you, thank you,
Now,
thank you, Micro Labs.
Thank you so much,
Thank you,
sir,
doctor.
taking time.
Thank you
Busy
all,
schedule.
and thank you for all
Yeah.
the participants who are being here.
Yeah,
Thank you
Dr.
very much.
Asir Julin is telling
Have a
good
happy World
presentation.
Digest today.
Thank you. Swakshar, you want to
Yeah.
say? Yeah,
Yeah, thank you, doctor, for giving us a insight into the GERD. We have learned a lot of things today, and we look for many more interactions with you, which is basically a platform where we can really disseminate to the different parts of the country, to different medical fraternity and all. And also, doctor, thank you, Dr. Manjula, for moderating the whole the things that webinar, and also Dr. Harsha, thank you so much. Thank you, doctor. Once again, Dr. Arun.
Thank you all. Thank you all.
Thank you. Thank you.
Thank you all.
Yeah, thank you. Thank you.
Dr. Harsha, you want to say something?
And wind up. Thank you all.
Yeah, thank you so much, sir.
Thank you. Thank you so
Pleasure,
much.
and
Thank you.
have a safe day.